Good evening. Thank you for joining us for the 2024 Mid-Year Immunisation Update. My name is Phoebe James. I'm a Professional Development Officer with the Hunter New England and Central Coast Primary Health Network. Before we go any further, I would like to acknowledge the traditional custodians of the lands that we're all meeting on today. We are coming to you here from Newcastle on wonderful Awabakal land, and pay my respects to elders past, present, and any First Nations people joining us this evening. This is being recorded and will be available in our education library on the website in the next week or so. If you want a certificate for this evening, please fill out the evaluation that will become available at the end of the session, and I'll get those out to you hopefully in the next week or so as well. Q&A, we have a wonderful team working behind the scenes answering your questions, and thank you to everyone for already sending some through, but please feel free to bombard them because they love to answer questions. We will break at about 7:30. We will try to keep to that time, but bear with us because we have a lot of wonderful information for you. It's now my pleasure to introduce the wonderful Sharon Saxby, Clinical Nurse Consultant with the Hunter New England Local Health District, Population Health.
Thank you, Phoebe. Hi everybody, it's lovely to be here again. We've got some, as Phoebe said, we've got some absolutely wonderful presenters tonight and some really great information, and we know that you're going to be really interested in what they have to say. We hope you've got yourselves all nice and comfortable on this cool evening and are settled back for a great night. So I would like to introduce Dr. Cohen Butters. Cohen is a general paediatrician and paediatric infectious diseases physician. He combines his clinical work with research at the Murdoch Children's Research Institute and teaching at the University of Newcastle, so he's got lots of spare time. He has specialist experience in infectious diseases, immunisations, common and unusual infections, infections in the immunocompromised. He grew up in Newcastle, did his undergraduate medical degree at Uni of Newcastle, paediatric training at the Royal Children's Hospital and Monash Children's Hospital in Melbourne. He's worked in rural Australia and Solomon Islands, probably not the same time as Paddy, but there's a commonality. Currently, he's completing a PhD examining the use of antibiotics in children with cancer. He has a young family and loves exploring all that Newcastle has to offer. Cohen, come on up. We are just really excited to hear what you have to say to us.
Had a quick mic change there, so hopefully that does the trick. Thank you, Sharon, for that lovely introduction. I was a bit nervous presenting tonight, but I was told that you'd probably be at home in your pyjamas, rugged up in front of the fire, and I hope that is the case. But we're here talking about something that's, of course, very topical in winter, but particularly this winter around RSV immunisation and an approach to RSV immunisation. So importantly, I have no conflicts of interest to declare. I don't work for Sanofi or AstraZeneca, but I do receive funding through the Australian government for separate research related to that PhD, which has no influence on these products that we'll be discussing today. So I'll start by providing an overview of the H&E Kids Immunisation Service, which I act as the clinical lead for alongside Professor Rani Bhatia, an immunologist, which is a relatively new service for the Hunter New England. We just celebrated our first birthday and over 1,500 immunisations delivered in that first year of service. Having said that, it's looking like an even bigger year with over 1,000 flu vaccines through that service delivered to children in the first month. So we'll also talk about RSV virology, and I'm going to keep that bit short because I do appreciate that it's late on a Wednesday afternoon into the evening. So we'll keep that bit short so you don't glaze over. We'll talk about the havoc caused by RSV disease in this country, talk about the immunisation and vaccination landscape, and talk about Nirsevimab implementation this year and why some tricky decisions had to be made, but also what it might look like in the future around Nirsevimab as well as vaccine implementation. So H&E Kids Immunisation Service is a Ministry of Health funded service. As I said, we've been around for about 15 months now. And the breadth of work that we do is quite broad, not nearly matching the amount of immunisation work that you do in primary care, no doubt. But what we're focused on is providing drop-in immunisations as per the NIP program for current patients at John Hunter Children's Hospital. And I think that's been a critical role because we do have a vulnerable group of children that are attending oncology appointments, cardiac appointments, but also moving through our general paediatric clinic, who we're finding many of them aren't up to date for their vaccinations and also haven't had the opportunity to get specialist immunisation advice. We're also providing flu vaccine as part of that, planning for catch-up immunisation, providing clinics, providing information after adverse events at that tricky end, discussion and advice around vaccine hesitancy and vaccine safety, and then providing specialist immunisation advice for high-risk groups, such as those patients who have had a bone marrow transplant, immunocompromised patients. And we've just, as of this month, taken over the BCG clinic for children, which was previously run by Chest Services. And alongside that, we're incorporating some basic travel advice. And I'm the first to say that we're not providing comprehensive advice and we don't replace a travel service, but we are providing just some basic precautions around travelling with children and young people. And then increasingly we're providing education both for our ward staff and supporting immunisation for our inpatients and starting to provide outreach. And I'm really proud of the collaboration we have both with primary healthcare and population health in delivering immunisation programs. So our staff consists of Professor Rani Bhatia and myself as the clinicians in the team, Kylie Pratt, our wonderful nurse immuniser, who's probably joining online tonight, and I really want to thank her for all of her hard work over the last 15 months. And then we have wonderful Chloe Gillies, who it's a wonderful outcome of COVID that she left Qantas and she's come to us, and that's been a wonderful thing for our team. We're located in the paediatric outpatient department. This must have been the opening day because it doesn't look like this anymore. It's normally pretty chaotic and there's people streaming out. But this is a wonderful captive audience here in this waiting room that we can talk to about immunisation and offer them a range of immunisations that we have well stocked and ready to go at all times. So how to refer? Well, our referral system has been incorporated into health pathways. BCG vaccination, we prefer that to be accessed through the New South Wales BCG vaccination page, and really a plug for BCG vaccination that we should be encouraging that for children less than 5 that are going to be travelling for 4 weeks or more to a country, but often that's cumulative and many of the families I see are going back at least every year, so it's a really important group to consider. And then those less than 5 years consider risk of TB exposure in Australia or living with someone who has leprosy, which I've not had a patient with that referral, but it's still part of the referral guidelines. And then we also have a referral form which can be accessed via the specialist immunisation page at H&E Kids Health. So let's talk about RSV protection, because I know that's why many of you have tuned into this first section this evening. So as I said, there'll be a short period of RSV virology, which I love and I could speak about all night, but I'll keep it short and painless for you. But RSV is part of the Pneumoviridae subfamily, and it's actually closely related to human metapneumovirus. And wonderfully, I think, it was identified in 1955 as a chimp cold virus, and they're responsible for causing viruses, for causing colds in chimpanzee. This is an enveloped single-stranded RNA virus, and the important component of this is that it's non-segmented genome. So the genome is pretty stable, and it's not subject to the same genetic reassortment and antigenic shift that we see in other important respiratory infections, like influenza virus that requires an influenza vaccine, an updated influenza vaccine every year, or indeed pneumococcal vaccine and the drift that we see in terms of pneumococcal infection. RSV is a ubiquitous pathogen, and we'll come to that in a moment, infecting almost all children by 2 years of age, and the most common cause of children under 2 to be admitted to hospital. It's easily spread through droplet and contact, and children are infectious for incredibly long periods. So that tricky question about when can I take my child back to daycare, I don't think there's a firm answer to that, because certainly infection out to 4 weeks has been identified. And RSV is incredibly hardy. It has the capacity to survive on surfaces for up to 6 hours and be transmitted that way. There's 2 key components, and these are important when we start talking about the vaccines and immunisation approaches. So the first of those is the G protein, and that determines the antigenic groups between RSV-A and RSV-B. It allows attachment to the host airway. It inhibits the immune system, importantly, and it disrupts that epithelial layer of antibody-mediated immunity. The F protein, though, is also expressed on the surface, and that's highly conserved between strains and critical to host fusion between the RSV and the epithelium of the respiratory tract, the lining of the respiratory tract. And RSV has this capacity as respiratory syncytial viruses to cause a syncytium, which meaning the viruses join together in terms of these and form these large bodies. So the pathophysiology of bronchiolitis is really important because that reflects what we see in primary healthcare and in those young children presenting to the emergency department. The virus attaches itself and affects the lining of the airways, of the upper airway, so it starts as an upper respiratory tract infection. But then those cells are broken off and aspirated, carrying RSV infection deep into the lower respiratory tract cells. There's rapid replication of virus, injury to the lining of the respiratory tract, massive production of mucus, massive recruitment of airway neutrophils and something called nets activated, and then we get huge amounts of inflammation. The cilia, which are the elevator which moves mucus within the airways, are paralysed by this infection, and the ultimate outcome is collapse and serious injury to the lung. Starting from A, moving through to C, this is infected cells lining the airway, infected by RSV, with progression over 5 days. What you can see in that first photo is the linking together of RSV, but by day 5, the dead and injured epithelium of the respiratory tract. How that presents clinically is either upper or lower respiratory tract infection, but in young infants they're certainly prone to apneas, and that's one of the reasons they present to hospital alongside poor feeding and need for oxygen support. It's commonly implicated in studies of severe pneumonia as a co-infection leading to secondary bacterial infection, and we think that's in approximately 1% of hospitalised infants with RSV that's a secondary problem. Then there's this serious condition that's rare but important of bronchiolitis obliterans, which the word obliteration meaning damage and severe damage to the lung, with often a lifelong need for respiratory support and oxygen at home. And then what's increasingly appreciated is the impact of early RSV infection on asthma and recurrent wheezing in later life. And it's estimated that RSV within the first 12 months can increase the risk of lifelong wheezing within the first couple of years and lifelong asthma by up to 5 times. We have an interesting pattern. I'm sure Dr. Murray might talk about this a little bit later, but the variation in the seasonality is important in different sections. So we had a slightly different RSV season this year, which started essentially in March as we were starting to roll out Nirsevimab, and so there was a real rush to activate this. But in other parts in the warmer areas, it's not strictly a winter infection. It tends to be throughout areas, throughout the different seasons, and a little bit linked with rainfall and humidity. It's estimated that RSV in Australian children is responsible for up to 7,000 admissions each year, but that is potentially an underestimate. And the cost of each of those admissions, the index admissions, so not accounting for recurrent admissions to hospital for poor feeding after discharge or recurrent episodes of wheezing, is estimated to be 12,500. So doing the basic maths, the cost estimated in 2022 was between $40 and $90 million nationally. And then when you start to add the readmissions in addition to the index admission, that cost quickly goes up to $120 million nationally. So we're talking about vaccines that are at a cost of $350 and immunisations that are a cost of $1,000. It does need to be considered in that context, not that I'll be talking about policy decisions today. When we're thinking about characterising risks, it's certainly important to consider underlying medical comorbidities like cardiovascular disease or respiratory disease. But I think what has been under-discussed and under-recognised is the significant impact that RSV disease has both on young and older First Nations Australians. And we can see here a 5 times higher rate of admission in our First Nations people. Increasingly recognised is the impact of RSV in older Australian adults. And as we've started swabbing and continued on from the period of COVID, we've started to identify the significant burden of disease in older Australians. And my colleagues in adult respiratory medicine are talking about this, about how many adults have RSV. And of course, it's not that they had RSV for this season for the first time, it's that we're identifying this as a significant problem. We don't have great data again, but hospitalised adults over 65 years of age is estimated to be 123 per 100,000 population, but that increases significantly in those over 75 years of age. And of course, there's a subgroup of patients with comorbidities that are very high risk for admission. So I think we consider this as just the tip of the iceberg. You'll have to pardon that. I couldn't help but put that in. Zooming out a little bit and looking at an international perspective, in 2019, it was estimated in children less than 5 that there was over 30 million RSV-associated acute lower respiratory tract infection. And I find it hard to grapple with those numbers, but it, of course, very significant. It was associated with over 3 million RSV-associated hospital admissions, of course, recognising that that's not the best measure in low and middle income countries of severity of disease. And then at least 100,000 RSV attributable deaths, including 45,000 attributable deaths in infants less than 6 months. Importantly, many of these children died at home without access to medical care. So let's talk about RSV prevention. And in the setting of those previous slides about the international impact, it would be good just to consider as we move through these slides about the role that these will play, not just in Australia, about the issues of equity and how we might go about ensuring access to these vaccines internationally. So to provide some historical context, this has been a long time coming, and that's why it's with such celebration that we have both a combination of monoclonal antibodies and subunit vaccines. We've understood RSV since 1956 when it was first discovered and its virology was first described. But this is important in terms of the history of vaccines. In 1965, there was a clinical trial using a formalin inactivated virus that was focused on the post-fusion protein. In that trial, many of the children were admitted to hospital after vaccination with severe RSV disease, and 2 of those children died directly related to that vaccine trial. Moving forwards, it took until around 1990 for us to fully understand the cause there and to fully map the F protein. And what was discovered in that understanding was that this original first live vaccine, formalin inactivated virus vaccine, developed non-neutralizing antibodies to the post-fusion protein, which meant that children given this vaccine actually presented with enhanced disease in which the immune system was overly activated and those infants were injured. But with further study of the pre-fusion F protein, we've been able to map that in extreme detail, and with that has allowed development of firstly palivizumab, and then further understanding and more recently development of nirsevimab, and a number of other monoclonal antibodies are in the pipeline. So when we look at immunisation strategies for RSV overall, they can be divided into 5 different categories. So it is a quite complicated vaccination landscape. The first of those is recombinant vector-based vaccines that use modified replication defective virus. The second of those are nucleic acid-based vaccines, which are mRNA vaccines, which certainly gained a lot of recognition and were crucial in terms of the COVID-19 response. And then protein-based vaccines, including subunit vaccines and whole inactivated virus. And the vaccines we're talking tonight fit into this category. Live attenuated vaccines, which may have an important role in terms of vaccination in later childhood. And then the monoclonal antibodies, namely palivizumab and nirsevimab, which has been important this season. So this is the vaccine pipeline from 2012 onwards. So you can see there, those vaccines in red were sort of dead trials that never completed recruitment. And then you can see this rapid progression of trials through phase 1, phase 2, phase 3, through to vaccines that are still in clinical trials now. So it's likely that we're going to have a relatively complicated vaccine landscape, and multiple formulations may be available in time. But talking first around those protein-based vaccines. So the first of those is RSV-P-F3, which is Arexvy. This is a recombinant subunit vaccine consisting of a viral F protein, and it's stabilised importantly in the pre-fusion conformation, recognising those issues with previous vaccines around vaccine-enhanced disease. And this is now TGA registered. It's recommended for all people aged 75 years and over, people aged 60 years and over with risk factors for severe disease, and First Nations adults aged 60 years and over. The phase 3 clinical trials of an unadjuvanted version of this vaccine were paused after a detected increase in preterm births was observed. So importantly, this vaccine is not licensed in pregnant women. The second of those is a really exciting vaccine, Abrivzo, and this has just received TGA registration for maternal use at between 24 and 36 weeks, playing the important role of passive immunity transmission of antibodies to the unborn baby. This is an unadjuvanted vaccine containing an equal amount of F proteins RSV-A and RSV-B, again stabilised in the pre-fusion conformation. Most of the papers I present today have actually made it to the New England Journal, which is no mean feat. But for Abrivzo, there was 3,500 vaccine exposed and a similar amount of negative infants at interim analysis. And what they found is that the vaccine efficacy for preventing severe disease in born infants within 90 days was 81%. And that was defined as requiring admission to hospital, oxygen therapy, intubation, intensive care unit admission. So that's pretty powerful. What we do suspect with these vaccines, though, is that efficacy would gradually drop off over the coming subsequent 3 months. And then, importantly, efficacy for medically attended lower respiratory tract infections, so presentation to an emergency department or primary care within 90 days, was close to 60%. Presented here in the upper graph are those is the reduction in medically attended severe RSV, lower respiratory tract infection, right out to 180 days, and you can see the significant impact of the vaccine on those presentations, and then overall medically attended lower respiratory tract illness, again out to 180 days in graph B. Importantly, neither of these vaccines, as you're probably aware, are part of the National Immunisation Program. And I did look up the cost of each of these vaccines at the moment, and the cost seems to sit around $300 to $350 for each of those. So at the moment, I suspect for many patients, they may not be financially viable. So thinking about the infant RSV immunisation approaches. So the key here is using antibodies that recognise the pre-fusion F protein and recognising that these provide the most neutralising activity. There's 3 components to the approach. The first of those is passively transferred antibodies from immunised pregnant women. The second of those is prophylaxis with monoclonal antibody, which is palivizumab and nirsevimab for the time being. And then into the future, potentially a role for live attenuated vaccine for active immunisation of older infants as either of these immunisation approaches, the vaccine antibodies starts to wane. So looking at passive immunisation through monoclonal antibodies. So we can see here the pre-fusion RSV F protein, and we can see this site /0 in the red. That's the component that nirsevimab antibody binds to, and it prevents fusion with the epithelium, fusion with human host cells, and replication. You can see on the right the powerful neutralising antibody potency. And what we know is that this shape of RSV is highly conserved, meaning that it's consistent between RSV epidemics and RSV infections across countries internationally. So the evidence to date. So I've tried to highlight in one slide very quickly the current evidence we have, the evidence prior to rollout that we had to support nirsevimab's use. And you'll come to quickly understand that the trials follow a bit of a theme in terms of their naming. So the first of those published in the New England Journal is the Melody trial, and the population was healthy infants greater than 35 weeks, which is obviously a safe place to start. And we found that there was a vaccine efficacy of 76% for medically attended lower respiratory tract infection. Second of those, again in the New England Journal, is the Harmony trial. And they look specifically now at the higher risk children, so those born greater than 28 weeks who were not eligible for palivizumab. So they weren't generally children with known chronic lung disease or cardiovascular comorbidities. And the vaccine efficacy in that higher risk group was now 83% for hospitalisation. In a further study, which is not completed yet, but known as Medley trial, this was in infants less than 35 weeks, specifically with heart or lung disease. And what they found is the majority of those participants achieved matched target serum antibody levels that would be suspected to match the vaccine efficacy of the previous trials. We know from these trials, firstly, that there was a sustained antibody at least out to 180 days, but measurable antibody out to 360. But the efficacy started to wear off from around 5 months for these monoclonal antibody products. And then what we were able to confirm in these studies, or see in these studies, was that across subsequent RSV seasons, that there was no signal of increased vaccine-enhanced disease and worse RSV in subsequent seasons. So talking a little bit now around the phase 4 effectiveness. So now this is real-world data about what nirsevimab is capable of when delivered effectively. So a lot of this evidence is from other parts of the world, and I think what we've seen is a very different approach in different countries in terms of the application and implementation of nirsevimab. So this is Luxembourg comparing 2023 to 2022 RSV season. And they're able to achieve, I think, pretty incredible neonatal coverage. So 84% of their infants around birth, as well as a catch-up program, received nirsevimab. They saw a 70% decrease in hospitalisations with RSV infection in those infants less than 6 months. And you can see on the right the difference in the epidemiology curve between the light blue and the dark blue. So clearly changing the rate of RSV infection and presentations to hospital. Those children that were admitted to hospital with RSV were of a much older age group, and you would expect that they're going to do much better in terms of their disease trajectory. And indeed, their hospital length of stay decreased from 5 days to 3 days. And in most interventions, it's very hard to make any kind of dent on length of stay data. Among the 240 children under 5 years of age who are hospitalised with an RSV infection in 2023, 88% of those were not immunised with nirsevimab. So this was a very powerful intervention when given essentially universally in a high-income country. You can see there on the left of the screen the 2022 age and number of hospitalised cases, and then you can see the stark difference in 2023 after implementation of nirsevimab. The Spain experience is really important also. So this is published in The Lancet. This was importantly a study that was funded by Sanofi and AstraZeneca. So in the 2023 immunisation program, they were able to provide nirsevimab to 91% of patients or participants in the seasonal and catch-up groups. And effectiveness was significant. So 87% effectiveness against severe RSV-related lower respiratory tract infection. That is a different kind of definition to what I would say is severe as a clinician, and really that was infants requiring oxygen, so that's important to recognise. But again, a 70% reduction in all-cause lower respiratory tract hospitalisation, a 66% reduction in all-cause hospitalisations, meaning that actually this seemed to have an impact on pneumonia and asthma at this early phase. So the way that we approached this in New South Wales, you may be aware, was that this was a targeted intervention. And the reason for that is that we're very fortunate to have access to doses in the setting of an international shortage, and so we needed to be quite careful around the way that these doses were delivered. The doses that we were able to access were quickly brought across from Germany from the end of their RSV season, and the remainder were brought across from Western Australia after their nirsevimab program started to wrap up. And so we needed to choose those highest risk infants. So this year in New South Wales, we aim to provide immunisation to all preemie infants less than 37 weeks born after October, all Aboriginal and Torres Strait Islander infants born after October, regardless of risk factors or gestation. And then we really focused on those vulnerable infants, including trisomy 21, neonatal lung disease, heart disease, immunodeficiency, and other complex conditions. And so I thought that was a really important way to allocate resources, and we really tried to speak quite broadly amongst a range of specialists to come up with those criteria to think about how we could allocate this resource. And certainly the feeling is anecdotally is that this has had a significant impact on rates of immunisation for RSV, rates of admission for RSV infection locally. So what does next year look like and beyond in terms of a potential approach to universal RSV protection? So it's likely to be a mixed picture. And so monoclonal antibodies are likely to play a key role in protecting premature infants. We know that they probably provide a longer duration of protection. And this is a program we can potentially provide flexibly based on the RSV season, starting it and concluding it starting it at the beginning of the RSV season and concluding it as RSV infection wraps up. And then alongside that, maternal vaccination, playing an important role in terms of providing broad protection. We know that maternal vaccination is less vulnerable to viral resistance, and we get indirect vaccination of the infant. So the infant doesn't require an injection themselves and tends to be more affordable overall in terms when compared with the monoclonal antibody vaccinations, immunisations. So moving forward, it's likely that RSV monoclonal antibodies will be recommended for those young infants who did not receive RSV vaccine in pregnancy, or those infants born prematurely who didn't have time for the antibody levels to cross the placenta and be delivered to the child. And then also we'll be likely to providing monoclonal antibodies to young infants who are at increased risk of severe disease, regardless of the mother's vaccination status, and then likely catching up those infants in their second RSV season who have risk factors for severe disease. The Australian Immunisation Handbook, excitingly, was updated last month with this algorithm, and this is, I think, what we are all waiting to see about how these vaccines will fit together. The next important part of the puzzle is who's going to fund these and who's going to support the rollout, and I'm sure that if we have time for questions, some of those things will come up. But really the approach will be in those mothers that have had good vaccination with the Abruzzo at least 2 weeks before delivery and the infant isn't at high risk, then they'll be considered vaccinated for that RSV season. But infants at high risk or those who haven't had the opportunity to have passive transfer of antibodies will require catch-up with nirsevimab. We'll need to think a lot because certainly this is a resource-intensive approach of providing nirsevimab to young infants, and we'll need to think about how this can be given alongside the National Immunisation Program recommendations. So I'll stop there, and if we do have time for questions, I'm happy to take those.
Thank you very much, Cohen. That was just a huge amount of information, fantastic information in a short space of time. I'm sure that there actually are already questions that we're going to throw at you later in the evening. We're saving all the RSV questions for you. And we knew that everyone else was really keen to hear what potentially is going to be happening next year, so that was really great. I'd like to introduce another wonderful speaker who's got a wealth of knowledge and he just loves sharing it, but he really wants to introduce himself. So I'll just hand over to Dr. Pete Murray. Thanks, Pete.
Good evening, everyone, and thanks, Sharon, for the introduction, the brief introduction. Cohen, that was spectacular. Great presentation, thank you. I think that would have been of great interest to you all, so thank you for working us through RSV and what the future may look like in RSV prevention. So I'll introduce myself. My name's Pete Murray. I'm one of the public health physicians at Hunter New England Population Health. It's a real pleasure to be here with you all tonight. Sharon gave me a formidable task this evening to talk about APHIS and then talk about any other interesting things from a health protection perspective. So I'm going to run through a couple of key issues that I think are relevant to you all. Key things I'm going to cover off tonight, winter respiratory illness, and give you an update on the epi in that space, talk about measles, give you a global update on what's happening with measles, talk about mpox, and finally, rounding that out, brief discussion about APHIS. So we're covering a couple of different bases here tonight. I always like these slides to start off with. This is what I'd like you to take home from tonight's presentation. So feel free to take a snip of this now and call it in. But no, just wanted to flag that. Just really want to really stress that we've had the perfect storm of respiratory infections this winter so far. And we've had high levels of viral respiratory infections, high levels of pertussis and mycoplasma pneumoniae as well. So it's really been a perfect storm, and it's unusual for all of these to hit at once. And currently we have high levels of influenza activity in across the state and also in the Hunter New England area, but we've got moderate COVID and RSV activity across the state and in our area too. And I really wanted to stress that pertussis activity is increasing quite sharply as well, so I'm going to talk a bit about that too. Also want to give an update about measles and the global, what's happening globally and what case numbers are doing globally, and really stress the importance of checking vaccination status prior to travel and thinking about that supplementary dose for any infants aged 6 months to 12 months who are travelling overseas. Also going to then provide an update about Mpox and just talk through the recent resurgence in cases that we're seeing in New South Wales, including in northern New South Wales. And finally, we're going to just talk you through APHIS. Professor Nick Woods last year gave a fantastic presentation in Terrigal about APHIS and the management of it and the vaccine safety landscape. And I'm going to talk through about the public health management of APHIS and talk you through your really important role in that and how you contribute to vaccine safety. So let's start with respiratory surveillance. I like starting with flu tracking slides, and the reason being is because flu tracking is a Hunter New England initiative. It's come out of the Hunter New England Population Health Unit. We get local data. This graph I'm showing you here is data for our area. And also it stayed pretty constant, the data through COVID. So the methods haven't changed too much. So it's really good to compare and contrast years past and to get an indication of how this year's tracking compared to previous years. And whilst the laser pointer is not going to be very helpful here, on the horizontal axis here we've got month, and on the vertical axis we've got fever and cough percentage. And what I want to draw your attention to is the black line there, which is the 2024 data. And what you can see with 2024, as we've headed into winter, we've seen a marked increase in fever and cough rates reported by our flu trackers. And now recently, over the past few weeks, it's dropped quite considerably. And we think that's got a lot to do with school holidays interrupting disease transmission. But we did have really high fever and cough percentage and respiratory illness being reported just at sort of late June and early July. And I want to sort of unpack that and look at what sort of the impact of the different respiratory pathogens have been for that, have impacted this data. Before doing so, just want to put a plug in for flu tracking. We're always looking for new members, and when we send out a link to the recording of this webinar, we'll send up a little sort of a flyer about how you can sign up if you're keen to be a flu tracker. Okay, let's then move on to COVID and see what's happening locally. This graph here is showing hospitalisation data for the Hunter New England area, which has been a really stable indicator over the COVID pandemic. And it goes all the way back to December 2021. So we've got a long time series there on the horizontal axis. And on the vertical axis, we've got the number of people who are in hospital with COVID. And what this shows very clearly are the different COVID waves we've confronted over the past few years. I'd like to draw your attention to the arrow with KP.3 on it. That is the most recent COVID wave that has hit us alongside everything else that was circulating. And that was driven by the KP.3 variant, COVID variant. What you can see though is that we're coming down the other side of that wave, so that's really promising. And in actual fact, whilst across the state we've got moderate COVID activity, probably locally we're probably sitting with low activity at the moment, which is good. But not only is the positive as we're coming over the other side of this wave, what I really wanted to draw your attention to, and this is where I've got the star going back 18 months, the last time we had hospitalisation figures this high that we had for this KP3 wave was 18 months ago. So this wave was a significant wave, and I don't think we really appreciated or expected it to be as significant as it was. Looking ahead into the COVID crystal ball, what's going to be the next 6 months, the next few years, what's that going to look like? And I do have some positive news there. We're likely to have a period of low COVID activity now that we've just come off a wave. But we're always watching very closely about what's happening overseas, looking at these new variants that are emerging. Some of the ones that we're watching, I've got up there on the slide. But unfortunately, I think we need to be preparing for another wave within the next 6 months or so, and that's been our experience to date. The other thing I think is really important to flag is that we're going to likely see new monovalent mRNA boosters be made available soon. Expert advisory groups from across the world have been saying we need something that matches better what's circulating. And those mRNA boosters are probably going to be a JN.1 or one of those sublineages, and that's what they'll target. So that's COVID. So just key take home with COVID. We're down into, probably have low activity in the Hunter New England area, moderate across the state, and we're probably heading into an interwave period now with low activity for the next few months. What about influenza? Well, this graph here is again showing Hunter New England notification data. And on the horizontal axis, we've got date going back to the beginning of 2023, and on the vertical axis, we've got the numbers of notifications. And what I want to draw your attention to is, firstly, you look at mid-2023, winter 2023, we had a good number of influenza notifications. And you can see there that there's some blue and green. And why I want to note that is because we had influenza B and influenza A circulating last year. But as we sort of move along and come to this winter, you can see we've had a marked uptick, in fact markedly higher than last year, of influenza notifications, and it's all blue. So we're just seeing predominantly influenza A at the moment. The key take-home, though, from this is that influenza activity is high in our area, but it looks like it's coming down, and I think it's an effect of school holidays, and we're going to watch this very closely to see if it keeps going down. Fingers crossed it does, but we're just going to watch the next few weeks very closely to see what direction it heads. But whilst we're seeing that decrease in notifications, we're also seeing that manifest in our ED presentations across the state. This data is showing influenza-like illness presentations, unplanned presentations to all EDs in New South Wales. And I just wanted to draw your attention to the blue line there. If we go on the horizontal axis, this is including January 2023 all the way to our most recent data. And I just wanted to focus on that last blip, that last wave towards the most recent data. You can see that it was a significant number of presentations to ED with influenza-like illness, but we're also seeing that drop. So it's sort of mirroring our notification data. So we've covered off COVID, we've covered off influenza. What's happening with RSV in our area? With RSV, it's only been notifiable since 2022, so we only have good data about notifications from the end of 2022. And on this graph here, we're showing RSV notifications from the 1st of January 2023 to our most recent data that's only last week. And you can see here we've got the first wave that represents the wave that we saw last winter, and now this towards the more recent period we've seen that other increasing wave, and that's the RSV notifications we've seen this season. So it's bigger than last season, but I think what I really want to stress is that not only was it high, but we're now over the other side, and we're looking like we're seeing decreasing RSV activity from our notification data. And when we look at hospitalisations for the 0 to 4-year-old age groups for bronchiolitis, and look at numbers of those who are presenting to EDs with bronchiolitis, we're seeing a similar pattern. Things are starting to head down, so we're moving from high activity to moderate activity like we are currently. Just want to delve into the Hunter New England RSV notification data a bit more. And this is looking at our data by age group. And please, it's a bit clumsy how some of the age groups have been carved up. But you'll see there that, like, if we're starting with 0 to 6 months, 7 to 11 months, and 1 to 4 years. And so the key take home from this is this: under the age of 5, the bulk of our RSV notifications, that's where we're seeing the majority of them. And I really just wanted to flag, and this sort of goes to Cohen's presentation, that it's the 0 to 6 and 7 to 11 months. We've got a really high number of notifications in those age groups, and they're the age groups that are the target of these RSV prevention, these new vaccines and monoclonal antibodies. They're the ones that are impacted by severe disease, and they're the priority for our RSV prevention programs. I also just want to flag, like we don't, as Cohen mentioned, we have had a number of notifications in older cohorts, but we don't really have a full understanding in Australia of the impact of RSV in older adults too. But looking at these data that I've got up here, we are seeing a number of notifications in those older age groups. So I've covered respiratory viruses. Let's cover bacterial respiratory pathogens. So let's talk about pertussis, because this is the one that's got me worried at the moment. What I've got here on this graph is Hunter New England notification data going all the way back to January 2010. So this is a nice long time series we've got here. And this is showing notifications received in our area. And what I really want to highlight from this is that you see that we get little waves that pop up over that time series. Periods we have increased pertussis activity, and we typically see pertussis waves every couple of years as immunity from the vaccine starts to wane. And the vaccine's very good at preventing severe disease, but it doesn't always protect us from infection. We see that protection from infection wane, and as that builds up and as that susceptibility builds up, we get waves of pertussis. Our last significant wave here locally, you can see there, was it was around the end of 2018, mid 2018 to 2019. And you can see that following that, pertussis notifications just flatline. And that's the impact of COVID and those public health and social measures. But over that period, some months we didn't even see any pertussis notifications locally, which is just remarkable. But what we were worried about over that period of time is, given that we're used to seeing and we expect to see waves of pertussis every few years, we've got this long period with no pertussis. So what's it going to be like when we start opening up again? And we've been raising concerns that we may see a really significant wave of pertussis once it got circulating in the community. And unfortunately, that's what we're seeing now. And you can see here right to the, well, it's my right, it'll probably be your left, of the graph, you can see at most recent data, we're seeing a sharp increase in pertussis activity. Now, importantly with pertussis, what are the age groups who are affected? So if we break it down a bit more, most of those notifications are in school-age children, age 5 to 14. And again, that's why it's really important to have that pertussis booster at year 7. So that's just a plug for that. But also just wanted to just raise with you that whilst we watch notification numbers, the group we're most interested in protecting with our pertussis vaccination program is those aged under the age of 6 months. So those really little ones. Because they're the ones that get really sick with pertussis, they're the ones that go to hospital, and they're the ones who have severe outcomes from a pertussis infection. And I just really want to flag the importance of the way we protect those infants is vaccination in pregnancy and timely vaccination at those critical points on the NIP. And vaccination in pregnancy is incredibly effective, reduces the risk for the infant by 90% of hospitalisation, so incredibly effective strategy, and it buys time for the infant to develop their own immunity to pertussis. Turning to measles, so we're jumping from another respiratory pathogen, but one we don't want to see and want to keep out of Australia. So I'm sort of obliged to give a measles update, given my boss is the chair of the Regional Verification Committee for Measles and Rubella Elimination, and I think it's always good to just reflect on what's happening globally with measles. This graph here is World Health Organization data showing global measles case numbers. And the different coloured colours in the bars are the different WHO regions that are reporting. And we're going back all the way to 2019 here. And you can see in 2019 it was a significant global outbreak of an epidemic of measles. We had huge case numbers, but the impact of the pandemic and public health and social measures, border closures, etc., meant that measles case numbers dropped precipitously. We also lost good surveillance in that time, so we can't really be sure that that's a genuine decrease in case numbers. But over this time, you can see 2020, 2021, very low measles activity globally. But at that same time, whilst COVID was disrupting everything, childhood immunisation programs globally went backwards, and millions of children missed out on important life-saving vaccines, including measles-containing vaccines. And our big concern from a global health perspective is that when the borders opened up again, when people started travelling again, we would see a huge resurgence in measles. And last time I spoke, I think last year, I was raising concerns about with the trajectory of the end of 2023 was that we may see a wave like we saw in 2019 with global case numbers at that level. Fortunately, what I can say, there's a good news story here, that hasn't eventuated. The beginning of the year, things started to look ominous, but over the past few months, we've seen potentially a decrease in activity, which is good. So that's good to hear, good to see. And noting there's a lag in these data, but it's a positive signal from our perspective. Looking at our sort of local issues with measles, like measles anywhere is a problem everywhere. And if we look at what we've seen this year to date, we've had 16 cases of measles in New South Wales, 9 of which have been from overseas acquired. So they've come into Australia with measles and acquiring their infection overseas. 7 of the case of the 16 have been import related, so have been linked to those cases. And what's really important is we understand those linkages. That's how we get on top of this and control it, and we understand it in detail. Thinking about vaccination status for those 16, we know that we don't know the vaccination status of 1. We know that 1 was fully vaccinated, 2 were partially vaccinated, and the remainder were not vaccinated. And of those who were not vaccinated, 6 were under the age of 12 months. And the reason why that's important for this audience, I think, is twofold. Firstly, the importance of vaccination. I think we need to now start thinking about not only measles vaccination in the NIP, but also thinking and reviewing people's measles vaccination status before they go travelling as well, making sure they've had 2 doses of measles-containing vaccine. And also, I think it's really important if there are infants who are going to travel to high-risk countries or travelling overseas who are aged 6 months to 12 months to consider the MMR0, that supplementary MMR dose. And I just want to stress that's an additional dose over and above the 12-month and 18-month dose as well. But it's an additional dose that protects them when they're travelling and reduces their risk. And finally, as I mentioned, whilst we've got measles globally, we're always at risk. So if you have anyone who's presenting with a clinically compatible illness, who's got a history of overseas travel, even if they're vaccinated or not, consider measles. Test, isolate, and call us. Mpox. Jumping to a different issue, but a really important issue, and this is an issue that's growing in importance recently with the increase in case numbers. So Mpox, we saw a large global outbreak in 2022, and that was subject to a public health emergency of international concern, so it was a pandemic. And what happened over that time is that we saw case numbers drop off with public health response measures, public health communications and vaccination efforts. Last year we saw very few Mpox cases in Australia. Unfortunately, this year, though, we're seeing a resurgence in Mpox cases, and it's a resurgence in the MSM population. So we're seeing lots of cases, and we're seeing evidence of extensive local transmission as well, and seeing transmission in places that we haven't seen Mpox previously, such as northern New South Wales, even in the Hunter, New England area as well. Other key changes, we're seeing that a number of these cases are unlinked, so there's evidence of sort of a wider transmission. And we're also seeing breakthrough infections in people who have been previously vaccinated. What is important, though, to note about breakthrough infection is it's very mild. It's presenting very mild with only a few anogenital lesions. So vaccination is attenuating the disease. And my key message, there's a really good Mpox update that's available, a GP alert that's available on the New South Wales Health website, and hopefully there's a new update coming out shortly. But just the key message about testing all MSM with compatible symptoms for Mpox, and remembering vaccination is important. Primary preventative vaccination is one of our key strategies to get on top of this resurgence in cases. Now, jumping around a bit here. So now let's move on to adverse events following immunisation. I'm just going to do a little time check. I think we're travelling okay. Yep, got the thumbs up, which is great. So this is an issue that, it's a fascinating issue, APHIS. And what I'm going to do is lift the hood on what we do in public health when we receive APHIS. And Professor Nick Woods last year gave a fantastic presentation on APHI management, vaccine surveillance, and all the infrastructure that supports vaccine safety and vaccine safety monitoring in Australia, and delved into some really interesting issues and interesting adverse events and adverse events of special interest as well. And I'm just going to talk about what we do and how we go about investigating and looking into APHIs that have been notified to us. Now, we've all seen the definition of an APHI and all very familiar that it's notifiable under the Public Health Act. But I just wanted to stress here this critical thing that I've underlined here, that an adverse event following immunisation doesn't necessarily need to have a causal relationship with the vaccine. So we're wanting you to notify things, even if we're not sure it's linked to the vaccine, but it's when you're concerned, when it's serious, when it's unusual. We want you to tell us so we can look into it. Now, I'm just going to go through the importance of clinical judgment. So APHI notifications, as Professor Woods outlined last year, is just one component of vaccine safety monitoring. But from my perspective, it's a critical component of overall vaccine safety monitoring in Australia. What's really important when we're thinking about APHIs, though, is that we need to understand what's expected. And so, most vaccine adverse events are minor, expected, and common too, such as pain, redness, and swelling. But we need to have evidence to tell us what is expected and what we can expect. And that evidence comes from vaccine trials, comes from international experience, and it comes from our understanding and reporting and monitoring of vaccines and post-implementation monitoring of vaccine surveillance. So, knowing what is normal, what's expected, and is very important when we're talking about APHIs. But we're not so interested in being notified about APHIs that are minor and expected. What we're really interested in are those APHIs that are serious. So there's been a serious consequence, death, hospitalisation, some nasty outcome. We're interested in APHIs that are unusual, and with your clinical judgment, it doesn't quite fit. It's not right. There's something not fitting there. It's not what we normally expect to see. Or it may be an adverse event that could impact vaccine confidence. And the classic one is post-MMR rash, which can be quite florid and be quite scary for family members, but that's something that can be notified through, and we can provide reassurance and help maintain vaccine confidence. I just really want to put a plug in for primary care and primary health care and general practice. We couldn't do our work in the APHI space without you. So not only are you a critical component of our whole vaccine program, you're critical for vaccine safety, because what you do is bring a clinical lens to things. You see the patient, you know what's expected. This is your bread and butter. And when you're notifying us of something, you're concerned. You have something that you think warrants further investigation. So it's already had a clinical lens and triage over it. So I just wanted to flag that you are critical. So when you notify us of APHIs, we take those very seriously, because it's had that clinical lens and acumen. It's had that perspective put on it. Now, this is an incredibly busy slide. It's intentionally busy because I'm not going to talk through each step, but what this outlines is all the different steps that we go through when we're investigating and managing an APHI in New South Wales, and this is what the Public Health Unit does. So I'm going to talk about just the high-level sort of key points around this that sort of feed into this slide, but basically, key take-home, there's lots of different steps, and we take them seriously and work through all of those steps for each APHI that comes through. So just sort of at a high level, what are our key sort of steps with APHI management? Firstly, we receive the notification. Sometimes that's through a TGA form, an APHI notification. Ideally, locally, it's through a REDCap form that we have available on our immunisation homepage. And once we receive that notification, the next step is to thoroughly investigate the notification. And we're looking at, the patient details, their medical history, previous issues with vaccines, allergies, medications, the nature of the event, how serious it was, how it was managed, the outcome, if known, the type of vaccine, how it was administered. We ask all of these questions, gather all of this information, because once we have that information, our next step is to triage. And that involves experts in immunisation and public health physicians as well, reviewing these data and sort of trying to identify and triage which avenue to go down. And you can see on that little picture there, there's green, there's yellow, and there's red. And these are the different ways we triage things. When we're triaging them, we're also looking for adverse events of special interest. And they're a special category of APHI. they're ones that actually we think have a causal or potentially have a causal relationship to the vaccine or the vaccine component. And a good example of that is Guillain-Barré syndrome, myocarditis following mRNA vaccines. And if we triage that and identify that it's an AC, that goes down a whole nother avenue and requires different investigations and involving different experts in helping support the management of that AC. When we're triaging, the couple of things that happen, we either identify it as a low-level AFI, and if it's a low-level AFI, what we do is we finalise the notification and then send that to the TGA for that national monitoring, or we identify it as a high-level AFI, and that's sort of the yellow and orange parts of that picture there. And a high-level AFI involves more extensive investigation, plus or minus the involvement of experts and potentially expert panels. For example, we've had expert panels of neurologists and immunologists providing advice on particular cases. And they're providing advice on the clinical management of the AFI, and also next steps, so monitoring and also advice around future vaccines as well. So quite detailed expert advice feeds into that. Once we've investigated, have had expert input, and potentially those experts have sort of provided advice around causation around the vaccine and the outcome, we then like to package it up as much as we can in as good a state as we can to send to the TGA and to notify through to the TGA so that they have as complete a picture and as well described an AFI as possible for their vaccine monitoring as well. And the final point, and it's a really critical point, is that this is all feeding into the TGA and feeding into their national surveillance, but we close the loop with the notifier. We close the loop, and ideally with the patient as well. And so this is just outlining what we did, what the outcome was, and next steps as well. So that's a really important component of just making sure people can see that their notification's been taken seriously and what the next steps are too. Just want to quickly dive into some data about notifications in the Hunter New England area. This is a fascinating graph, and I remember it was a very busy time during COVID from an AFI perspective. But this is an AFI notifications in H&E by year. So the blue is 2021, the green's 2022, and those ones at the bottom are 2023 and 2024. Normally we get a handful of AFIs a week, or a handful a month actually. And usually they're sort of childhood IMS related AFIs and we can work through those pretty quickly. But with COVID, we had new vaccine platforms, we had no COVID transmission locally, so we had no community-wide transmission. And then we were rolling out a very ambitious program. And so what we saw is AFI notifications skyrocketed over the course of the vaccine rollout. In some cases, we're getting hundreds of notifications a month. And that's just sort of shown in that 2021 blue line there. But that was critical information to be fed through into vaccine safety and vaccine safety monitoring. And it was pivotal in a number of key outcomes that influenced the vaccine rollout. And two things I just really wanted to highlight of great importance. Those notifications fed into our understanding about myocarditis post-mRNA vaccination, who's at risk, how it's investigated and how it's managed, and also what are the longer term outcomes with that. It was also critically important when we had some tragic cases locally of thrombosis with thrombocytopenia syndrome, which had significance for what vaccines were recommended for what age groups. But we couldn't have investigated or been made aware of these issues and concerns and without those notifications from our concerned clinicians. So just wrapping up AFIs, I think just really wanted to stress that notification is important to help ensure vaccine safety and that we've got good vaccine safety monitoring. It's really critical as well because we can link people who have been impacted by an AFI, who have suffered an AFI, with clinical support and expert support to help manage the adverse event, but also provide advice about ongoing management and future vaccinations as well. And finally, and this is the most critical point, it's about helping maintain vaccine confidence as well. That's all from me. Thanks so very much.
Thank you so much, Pete. That was absolutely fabulous. So two absolutely wonderful presentations, so much information for you guys to absorb. We're actually going to take a break now. and we'll come back with our bits after. So we're going to have a 10-minute break. So go refresh that cup of tea, that cup of coffee, that, dare I say it, that glass of wine. Put another log on the fire, and we'll see you back in 10 minutes.
I'm gonna take you on a ride. We're gonna burn through the night. Why you're so salty? I'll still take a bite.
Okay, you can take my Lambo. I'll put on a tight show. You sure you can handle? We be faster than Django.
I'm gonna take you on a ride. We're gonna burn through the night. Why you're so salty? I'll still take a bite.
We can take my Lambo. I'll put on a tight show. You sure you can handle? We be faster than Django.
Can't stop, won't stop. I can't stop, won't stop. I can't stop, won't stop. Can't stop.
Can't stop, won't stop. Can't stop, won't stop. Can't stop, won't stop. Can't stop. Okay.
I'm gonna take you on a ride. We're gonna burn through the night. Why you so salty?
You sure you can handle? Okay. We can take my Lambo. I'll put on a tight show. You sure you can handle? We be faster than Django. Can't stop, can't stop, can't stop, can't stop, can't stop, can't stop.
Can't stop, won't stop. I can't stop, won't stop. I can't stop, won't stop. Can't stop.
Can't stop, won't stop. Can't stop, won't stop. Can't stop, won't stop. Can't stop. Can't stop. Can't stop.
So welcome back. I hope you all enjoyed your little break. So we've been hearing a lot about the impacts that all these diseases have been having on our community. So what's the one thing that we can do? We can vaccinate. So we're going to have a quick look at our vaccination rates just through Hunter, New England. There's a really great little quote that I have that I got from somebody else actually, that vaccine saves lives but fear endangers them. It's a simple message that parents need to keep hearing. And that is a simple message that we need to keep having with our parents. So if we go along and have a look at childhood immunisation rates, these are Hunter, New England rates. We're looking here at our 12 to 15-month-old children. And you can see that the blue line is our Aboriginal children and the red line is our non-Aboriginal children. And within the last 3 to 6 months, we've had this beautiful uptick. So we almost have an equivalent rate of vaccination. So this is measuring vaccines all the way up to 6 months of age. So that is really, really encouraging because we did that little drift off during COVID. And so now we're seeing a little bit of an improvement, especially with our Aboriginal children, which is absolutely wonderful. Pre-COVID, our rates were up around the 95.9, 95.7, so we haven't quite got back to our pre-COVID rates. So we've still got some work to do in that aspect. This is our 24 to 27 months. So this is measuring vaccines given all the way up to the age of 18 months. And we can see that we still have that little bit of a gap. And it's actually doing a bit of a decrease. Okay, both Aboriginal and non-Aboriginal are slightly decreasing here. So that is a little bit of a concern for us, and the gap is actually widening up. Why is this? We're not sure. It appears to be around timeliness of vaccinations, but we still need to address that issue. Once again, here we are still not back to our pre-COVID rates. So it looks like we were doing a little bit of an upswing for a while there, but we've done another little bit of a dive. So there's more work to be done. At 60 to 63 months, which is measuring just our 4-year-old vaccines, so there is here an assumption that all the other vaccines have been given. So we do need to be careful when we're checking our children to make sure that when they come in for their 4-year-old vaccines, that they've actually had everything else. And here we can see we've actually, our Aboriginal children, well back in 2013, overtook our non-Aboriginal children, and that is thanks to our wonderful work done by Katrina Clark and Natalie Allen way back when with the pre-cooling system, which you'll talk about a little bit later. So we have maintained higher rates for our Aboriginal children than our non-Aboriginal children since then. And it is just a wonderful thing to see, which actually goes to pointing that our issue may well be timeliness of vaccinations, which we still need to address. So we can see that we're sort of plateauing along there for the last little while, but we still haven't got back up to our pre-COVID rates. So still, there's lots of work to be done everywhere. Influenza vaccination rates across the place. We have seen, like Pete was showing, there's been a huge amount of influenza A in the community. With vaccination, we actually got off to a slow start in New South Wales. And it hasn't been until the last month or so that we've really upticked with our vaccination rates. And you can see here New South Wales rates are below the country's rates. But in Hunter, New England, we've got that little bit of a higher rate, which was absolutely fabulous. But you can see that our young children rates are still quite low, and they are of a major concern. So this is for all people. And this is our Aboriginal and Torres Strait Islander data. We can see in New South Wales, we're actually doing better than all people, which is absolutely fabulous. And Hunter, New England, we're doing really well as well. But once again, it is that younger age group that have got those really low vaccination rates, which is a concern for all of us. So there's more work to be done there. School vaccination rates. I usually like to do a really big presentation on the school program, but not today. We're just going to talk about school rates. There's a new strategy out, a new immunisation strategy that says immunisation is everybody's business. And so this includes school vaccination rates. So here, just to recap, in Year 7 we give a DTPA in the form of Boostrix and HPV Gardasil 9. And Year 10 we're giving a meningococcal ACWI in the form of Nimrinrix at the moment. So here I've just captured the rates for HPV, DTPA and meningococcal ACWI for both Hunter, New England and for Central Coast, because I know we have a lot of our Central Coast counterparts on the line tonight. You can see here that for us, these are really disappointing rates. Okay, so we have HPV has been reduced to 1 dose as a complete schedule, and we would have anticipated that vaccination rates would have gone up with that. But since pre-COVID, we've actually seen the rate of consents decrease, and that has steadily decreased ever since, even now that COVID is finished. So that's a major concern for us, especially with our Aboriginal young women, as we know that HPV-related cervical cancer and death from that is increased fourfold with our Aboriginal women. So there's a lot of work, and you guys out there can be part of the solution along with childhood vaccines. I think we need to see school program vaccines as an extension of childhood vaccinations. We have had lots of calls from people saying we've had a student coming in saying they've missed their school vaccines, but when I look on air, it says they're not due. So should I be giving them? Our simple answer is if they're in Year 7 or up and they have missed their school vaccines and they're not recorded on air, then please give them. We give vaccines now in the school program and it's all online. We don't give them online, sorry. We actually give them the proper way, but we record everything online. And those records should be on the AIR within 24 hours of administration. So if a student comes into you and they're not there, please give them. The AIR is actually dictated by rules. Okay, so DTPA and HPV don't become due on air until the age of 14 years, and they're overdue at 14 and a half years. And meningococcal at 16 and a half years that it's due, and 17 years that it's overdue. So we know that kids are in Year 7 anywhere from the ages of 11 to 13, possibly 14, but not likely, and in Year 10 from anywhere from 15. So there's very good chance that those children are coming in to see you before they're actually due as far as AIR is concerned. And we need to remember that AIR is not a clinical tool, it's just, and it's guided by rules. It's also good to remind everybody of Australia's strategy to eliminate cervical cancer by the year 2035. But we can only do that, okay, through maintaining really good vaccination rates. And this means that Australian women and people with a cervix will have inclusive and equitable access to vaccination, okay, along with screening and pre-cancer treatment and cancer management services to meet their needs. So we need to really make sure that we get in and offer those vaccinations to all of our students. And of course, it's most important to be giving them before they become sexually active, so before they're exposed to those HPV types that cause cervical cancer. I think you all know all of these strategies, and I'm sure that you implement most of these strategies all the time in your services. So your personal recommendation normalises vaccination schedules. Okay, so your parents want to hear your personal recommendations and they want to hear your confidence in vaccines, and that impacts their confidence in having their child vaccinated. Seeing if you can let families drop in, having clinics after hours, on weekends, sending reminders, helping the parents make their next vaccine appointment at their current visit, making sure the timing is right. So we're not sending people away because the gap is incorrect. Checking the AIR record every time so you know you're giving the correct records and the correct vaccine, and have a look and see if they're due for any other vaccines. I think you're probably all familiar with these resources about who might have had what when. We can't assume that every person would have had the vaccines that are on the current schedule. Okay, so it's always good to check when vaccines were actually on a schedule, when they were given in school, just to see that you make sure that you can look back. My husband recently went overseas and was knocked back for a Hep B. The doctor wanted to check his serology first because surely he would have had it when he was in high school. I had to have a bit of a giggle about that. My husband is well and truly retired. This is also a really important place to go for resources. So this is Sky, sharing knowledge about immunisations. We're talking about having conversations with parents, having confident conversations with parents. There are lots of resources on Sky for health professionals to guide you in having those conversations, but also resources to give to parents. They're going to have lots of questions, and this is a great place for some resources. So please make that one of your go-to places. So in summary, those important immunisation conversations are more important now than ever. And we've been hearing about the risk of disease re-emergence, especially with measles and other things, and we are at risk if we let our vaccination rates drop. Okay, so we need to be very careful that we maintain those high vaccination rates. So thank you to all out there who immunise. You do an absolutely fabulous job, and I'm sure you all know that you are a lifesaver. And I'm sorry, but you've got me for the next presentation as well. We were meant to have a break in between. We were going to have Casey Wisemantle come along tonight, but she unfortunately was unable to come. So I've sort of stepped into her place, and I'm not going to do as good a job as Casey would about talking about AIR and reports and things. So I'm just going to give you a really brief overview and show you where you can go to get resources to how to make AIR work for you. Because we do know that AIR has its own challenges. So we're going to talk about AIR reports. We're going to talk a little bit about overseas vaccination records because they drive us up the wall, and catch-up plans, which is sometimes like chasing a dog chasing its tail. So our AIR reports. I'm sure a lot of you actually already use the AIR 10A report for your practice. This is where you can request a report from AIR, and it's going to be by provider. Okay, so you can extract this report and it's going to identify individuals who've been seen for a Medicare rebatable service at your practice, okay, who are either due or overdue for vaccinations on the NIP. These are really important reports to be able to get. You can go on, you can request these reports, and you request them to be provided to you once a month. So it's going to provide you with this rolling update of overdue children. On the immunisation community of practice, from the PHN, there's some beautiful resources there on how to actually extract those reports. So I really encourage you to go and have a look for those. What are you going to do with those reports? This is where you obviously can identify your individuals who are overdue for vaccinations. You can also go in and do data cleaning and correct immunisation data. So when we actually extract one of these reports once a month, there's a lot of data cleaning that needs, and that can sometimes mean you identify duplicate records. For some reason, kids are on 2 different Medicare numbers and they haven't been linked, and so you've got one child is up to date, but the same child on the other record is not up to date, so it's going to be an overdue child. There's records on there that are potentially incorrect, And having said that, when you look at PROTA, instead of when you look at the child, don't go down and automatically create an immunisation, what's the word? The immunisation record. Look down, do the drop box down the bottom and have a look at the records online, because if there's any records there that need to be, that are pending, meaning they haven't been cleared straight away, they're going to come up as overdue records up the top. So you might find that this kid's due for all these things, but if you don't look correctly and correct records, then you might give extra vaccines that are not required. So there might also be recording errors, and there might be errors in transmitting that vaccination encounter through to the AIR. So once again, Services Australia has a really good resource on how to be downloading those reports and managing immunisation records once you're on there. But of course, if they're overdue, truly overdue, recall them and send a reminder. Overseas vaccination records. We've been getting quite a lot of calls recently with providers having families with multiple people in them coming in with their overseas vaccination records. And this can be sometimes a really messy and complex task at times. So sometimes they need translation, and that is beyond most of us, really. So where do we do with those? What do we do with them? If you're in the private health sector, there's a couple of options for you. You can use the free translating service from the Australian government. So that's for anyone who has a permanent visa. There's also the TIS. That's where GPs and medical specialists can access when providing a Medicare rebatable service. They are time consuming and you might find them frustrating, but they are your resources to use unless you've got access to another translator. There's actually another document that's in the download section on the CapShot calculator, and it's there under the foreign language terms document. So it could well be very useful. It depends if the document's actually readable. So it can list the foreign vaccines and give the interpretation in other foreign languages, but also it can, there's another one where it's vaccine by trade names. So it will give you the trade name of the vaccine and it will give you the antigens that are in that vaccine. Because we all know that it can get really complex. Sometimes they're incomplete and sometimes they just have ticks next to them, and sometimes they have dates and sometimes they have a signature. Often they don't have a signature, so it can be really complex things. If you're in the public health sector, you can use the multicultural health translation service, and this can only be accessed through Public Health, Hunter New England Health, and you can access the contact details on our intranet. But the time turnaround is usually around 2 weeks. So, if you've got overseas vaccination records and there's no AIR record, you're going to need to create a record. A lot of people assume that if there's no Medicare number, then you can't create an AIR record, but you actually can. And it's fairly straightforward. You need the child's full name and their date of birth, and then you select record encounter and you follow through the steps. You're going to have to identify them and put in some more details like gender and their address. Once again, Services Australia website has some really good information on how to create those records. What we suggest though is when you've created a new person, you don't go in and put all their vaccination records on there, because nothing will happen to it. Just record one encounter, like the 6-week vaccines, and then depending on the urgency of you needing to get those records on, you could wait 20 minutes and phone AIR on their general number and just request that record becomes live. And that then means you can go back in to AIR and that person will be there, their record will be there, and you'll be able to put the remaining vaccine encounters onto the AIR. If you're not in such a hurry, you can park that one, come back in a few days, search for the person and you should be able to find them. If you do wait for a couple of days and they're still not there, I'd be calling AIR at that time, just to make sure that you can access their vaccination records. We need to be really careful that we don't assume what antigens are in a vaccination. As we know, all penta vaccines are not equal. And you can see there by that really lovely record on the right, that was just a snip from an overseas record that I think several people had actually attempted to upload onto the AIR. So in there somewhere we have a generic DTPA, we have an Immunorix Penta, and we have a PDSL. So each of those vaccines contain similar antigens, but not quite all the same antigens. They're all given on the same date, and we know that correctly that child did not have all of those vaccines. So that creates a really messy records, and it creates real confusion for people who are then trying to figure out what that child's actually have. So there's a wonderful vaccination schedule list on the WHO website where you can actually look up the different schedules for all of the different countries, and it will tell you what was given, what antigens were given or on the schedule for that country. So it's really important that we actually confirm what's in those vaccines before we record them onto the AIR. If you put incorrect vaccines on there, someone's assuming that they're vaccinated and potentially they're not. So if you're unable to confirm the brand of the vaccine given overseas and the antigens, we need to record it in air as a generic vaccine. Because a penta here is not a penta somewhere else. So when we add overseas records, it's very important that we make sure that they go in as performed overseas. We choose the country that they were given. When we go to the schedule section, we need to pop in other. And if we pop in other, that means when we get to the vaccine and the dash brand, we can pop in generic. So we start typing generic, and all of the generic vaccines and antigens will come up there. So we can see that most of them are single antigens, but there are a couple that are coupled up, like DTPA. I don't think we give them separately anywhere. So you just pop them in as generic. That means we know that they've had those antigens, but we just don't know what vaccine brand it was. Catch-up plans. There's a lot of vaccination catch-up plans champions out there, and we know that they take a lot of work, and we really appreciate that sometimes families arrive with just immunisation records and expect you to be able to work it all out in that 15-minute appointment and vaccinate them with a whole lot of vaccines. And we know that that's just an unrealistic expectation. So we are more than happy to help you with your catch-up plan. What we do ask, though, is that to make that process a lot easier, don't just hand us the records and say, please give us a catch-up plan. Do your best to add all those records to the AIR. Create a plan for yourselves. See what you think, and then call us. Okay, or email the records and ask us to review them. We're happy to do that. There's a load of resources out there to help you. There's the catch-up calculator. There's also other things that we have to keep in mind. There's the chapter on catch-up vaccination in the handbook. There's also additional Commonwealth and New South Wales funded free vaccines that we need to keep in mind for our older children as well. And on our website, we actually have some templates, some really great templates that you can use as a starting point for kids who have had no vaccines and fit into certain age brackets. And they will then outline what vaccines are due for that child. So I'm hoping that you're all familiar with our immunisation page. It's full of a wealth of information. It looks like that picture on the left. You've got lots of topics to choose from. There's information for health professionals. There's our To The Point newsletters are all there. A list of our free immunisation clinics for childhood vaccines. And our Aboriginal and Torres Strait Islander people, education, all sorts of things. And there's our contact details down the bottom there. Please, we love to chat. We love to know what's going on out there. We love to help you, and we are more than happy to assist you with whatever you need. So in summary, if you're not already, then request the recurring AIR 10A reports to help you identify your overdue children and incorrect AIR records. Make sure that your overseas vaccination records need to be in clear English before adding to AIR, so you need to get them translated. Use generic if you're unable to confirm that brand. Add all your records to AIR, create a catch-up plan and contact us. We're more than happy to help. So keep on vaccinating. You're doing an absolutely wonderful job. Thank you. I hand over to Katrina Clark.
Well, good evening, everybody. So as Sharon said, my name is Katrina Clark and I'm a proud Barkindji woman from far western New South Wales, and I'm the Aboriginal Immunisation Manager here for Hunter New England Local Health District. Prior to starting my presentation, I would just like to acknowledge country. So it's with great pride, I like to acknowledge the many lands on which we all live, play and work on, the unceded lands of Aboriginal and Torres Strait Islander peoples. I pay my respect to our elders who have paved the way for me to be standing here tonight. I will continue their dreams and aspirations with my actions, my voice, in advocating as we aim to move to a place of equity for all. I will also like to acknowledge each and every one of you online this evening, working in partnerships to ensure Aboriginal communities receive the best possible care, possible outcomes that will not only affect today, but our future generations. Following the presentation, I would just like to provide, or hopefully you'll take away a understanding of the current vaccination rates in Hunter, New England and factors influencing these rates, as well as identifying potential strategies to address behavioural and social drivers affecting vaccine uptake in the Hunter, New England context. So what is happening? So as Sharon mentioned earlier, vaccination rates have been declining. It's been consistent in all age groups, and it's all been declining since early 2020 across all age groups. So why? What do we know about what is going on? I know we have lots of ideas, and I know we're hearing lots out there. It's in the media, it's COVID. Everybody's tired of COVID. They don't want to get vaccines anymore, and it's just poisoned everything for vaccinations. Now, I'm not saying it's not a factor, but what I'm going to show you is some early evidence around what we know the factors are so far, and I have to say hesitancy is not a factor. It's not coming up in all cases with all people, but there's so many other things as well that is going on. So it's just not hesitancy. Over the past few years, I've heard the word so many times, and it's just like a get out of jail for free for governments and organisations to say, because they can say it's all their fault. They're hesitant. They have questions. They don't trust vaccines. And what's wrong with them? One of the things that I've heard over the past few years is it's more of the practical factors, the accessibility of vaccinations. It's just not there. Accessibility. It's just not there. It's not good as we all think it is. It's not enough that we have a free program if we can't get vaccines in arms. Now, I'm going to unpack this a little more, but I really just like to get the message out there. So when you hear people say, oh, it's the vaccine hesitancy, I really want you to say as well when you hear it is, but what about all the rest? What is also happening? What are the rest? So this is some early findings from a research project that we've been working with the Menzies Research Centre in Darwin. We've interviewed 16 interviews in the Northern Territory and Hunter, New England. It's to explore the appropriateness and the acceptance of a vaccine barrier tool. So for Aboriginal and Torres Strait Islander families, as mentioned in the Northern Territory and Hunter, New England local health district. So we've interviewed a range of government and Aboriginal and Torres Strait Islander community health services. Most people we interviewed provided immunisation services to communities or provided support to immunisation providers. There were differences across the Hunter, New England and Northern Territory, but there were also some similarities. The COVID experience has generally not impacted parents' perception of childhood vaccination in Northern Territory. However, we know from our local COVID response the people in Hunter, New England were impacted more. However, we are yet to talk to these families about the barriers and challenges of childhood vaccinations. So the two main things, health services and provision and clients' ability is to get these vaccines. As I mentioned earlier, vaccine hesitancy was not a big issue. All health service providers, practitioners said there were very few anti-vaxxers in their local communities, but access barriers was the biggest issue. So transport and most parents accepting of vaccines and willing to get their children vaccinated. Again, so our early findings for our family focus groups, concerns were about the safety and the effectiveness of access issues like the cost and the appointments availability are a significant associated with a partial of vaccinations. There was quite a few gaps in immunisation as well. So families were worried about the limited knowledge around the vaccine, so they were seeking more information, trust and confidence in the vaccine. So they were concerned about inexperienced staff as well. So this was a major concern for Northern Territory, as I said, focus groups as well. So we haven't really had a chance to do our focus groups here in Hunter, New England. So what are the practical things? So what can we do? Here at Hunter, New England Local Health District, we've been running a program. It's called the Aboriginal Pre-Calling Program. So this program was implemented in Hunter, New England in 2012, where Aboriginal health workers call Aboriginal families. So that's families of all bubs that were born in a Hunter facility and the child is identified as Aboriginal or Torres Strait Islander. So we're calling our families when that child is 4 weeks of age, just to remind them about bubs' upcoming immunisations. We also talk through all of those barriers. So if they do have an appointment or if they have issues getting an appointment, access like transport, or if they don't have a GP, we provide that support as well. So liaising them with, contacting them with their GPs or Aboriginal medical services. We also send out text reminders, so 2 weeks prior to each immunisation milestones. So if you do have any of the families coming in and saying that they have received a text message, the majority of the time those text messages are from our service. So that's myself or another Aboriginal healthcare worker calling those families and sending out those little courtesy reminders. So as Sharon mentioned, we've a huge issue is our timeliness. So we need to really encourage our families to get immunised on time. What we're also doing at a public health level, so we work alongside the high school immunisation team, so where we visit all the majority of high schools within Hunter, New England, and we're linking up with our Aboriginal education officers in our priority of schools as well, because we have seen a decline in our high school vaccination rates. As Sharon mentioned, it's all gone online now, so we need to also try and encourage all of our families to download the Services New South Wales app and to sign those consent cards. So this is just some of the practical things that we've been doing at a public health level. So strategies really for everybody to really consider to improve immunisation rates is to really engage, to build trust with community. And another thing that's really been coming up through lots of focus groups and talking to service providers as well is we need to empower our reception staff to be vaccine champions. They're the first ones that take the phone call from our families, and they're the ones that we see when we first enter a GP service. So if we can empower our reception staff to be empowered to ask the family about their vaccination rates, not just mum and dad, or asked about the whole family, especially around influenza season, just ask if you would like an influenza vaccine, just like at McDonald's. Would you like fries with that? Would you like a vaccine with that appointment? We just need to make it more practical and make it immunisations everybody's business. And the bottom one, we all know the research shows us that a personal recommendation or a healthcare recommendation to a vaccine, the research shows us that it's highly effective with families taking up the recommendation if a healthcare provider provides it. More practical is to remind, prompt, and to make services convenient, set up reminders, recall systems wherever you can, and to expand your community outreach clinics. So have clinics after hours, have clinics on weekends. We need to make immunisations accessible for everybody. We can't just have this great national immunisation program if our families can't get to the appointments. And in summary, so as I said, the NIP and influenza vaccination rates have been dropping. Accessibility is a major factor, even though we have a funded program, and we also still have concerns about vaccine safety and effectiveness still persists. But thank you. Oh, sorry, over to Kirsty.
Good evening, everyone. I'm Kirsty Waller. I'm one of the nurses that works in the immunisation team. I am going to whip through my slides because we still have Cohen in the room here and we'd really like to save some time for some questions at the end. So a quick rundown on the healthcare worker and student vaccination policies. So there's a policy within New South Wales Health, as most of you would know, that has actually just been recently updated. So in May of this year has been updated. Now the key highlights from that change have been that COVID-19 vaccine is now only recommended and not actually mandated or required for healthcare workers. The other key change is that the influenza vaccine is mandatory between the periods of the 1st of June until the end of September for that year. If a staff member declines, they need to talk with staff health around managing that, but actually the time period is now mandated between, as I say, early June to the end of September. So vaccine preventable diseases that we need to make sure we've got some vaccines in arms for. There's a quite extensive list there. Now again, the other key thing that to just take away from here and the change is that we are now allowing temporary compliance for hepatitis B, but also now for MMR, varicella and TB. The evidence of protection that is required to become compliant within health is quite extensive, and you need to tick a lot of boxes. So essentially, the easiest thing to do is if you have an immunisation history from a patient and it's on one of these cards and it's not completed to the requirements, just make sure all the vaccines are added to AIR. So that would be the quickest and easiest way to get around that. Always ensuring that minimum gaps are maintained, obviously between vaccine doses. As we all know, not all of us start work in health at the age of sort of 18. There are people coming into health at all ages and all times, periods of their life. So if you're looking for historic records for people that were born prior to 1996, it could be quite challenging. So the AIR has only been available for all ages for the last few years. So people that have histories prior, particularly to 1995, you're going to have to start by doing serology and just trying to find what records you can. Now, hepatitis B, there are very specific requirements around what you need as a healthcare worker, because obviously when someone works in health, they're at increased occupational risk of contracting hepatitis B. So that is the reason we need to have serology results. So just a note on this slide really that we can only consider someone a non-responder for Hep B if they've had 6 documented doses of hepatitis B. MMR and varicella, you don't need to do serology for if you've got 2 documented doses of vaccine. And again, if you've got any concerns or questions around these requirements, please reach out to us at the Public Health Unit. Just a few other quick hints and tips. Bone marrow transplant patients are now able to have funded vaccines. As we know, they require revaccination after treatment, these patients, and so it's fabulous that now, a couple of months ago, funded vaccines are now available through New South Wales health facilities. Unfortunately, that's the only pathway to access these funded vaccines. So please, if you are seeing patients that are post-transplant, please direct them back to their specialists or to their outpatient services. Oops, sorry, went the wrong way. And the other thing just to make note on is that on the 1st of July there was a very slight change to the immunisation schedule, and simply it is to do with funding. So Year 10 and the adolescent meningococcal ACWY vaccine is now optional to have Nimenrix or Menquadfi. Now, I believe Menquadfi is not available to be ordered as yet through the State Vaccine Centre, but it will become so shortly. Also, another note on Immunisation Hexa and Vaxelis. So just remember that you can provide either vaccine for little ones. We do try and stick with the same course of vaccine through those first few months of the schedule. If that's not possible though, you can alternate between the 2 brands. Just remembering that we need to always reconstitute Immunisation Hexa. You don't need to with Vaxelis. And if you're having trouble ordering Immunisation Hexa through the Vaccine Centre, please remember about the Vaxelis. With ordering of vaccines, again, just some reminders. Please make sure that you are only ordering 2 routine orders per month, and the key message is that you need to plan ahead because we've had an increased uptake of people ringing to ask for extra orders. So that's really not desirable, so you really just need to plan ahead, please. This is a contact for our team. Most of us have talked here tonight. We've got Sonia Davison, who's another RN in the office, and Michelle, our admin. And there's all our details there. Health Pathways have some fabulous resources. There's login details there for both LHDs. And I think that's my last slide. But hopefully we've got 5 minutes or so for some questions. So I might hand over to Sharon and Cohen again.
Big thanks to Kirsty and Katrina, fabulous. Apologies if we sounded a little bit rushed towards the end. Our wonderful speakers at the beginning, we gave them flexibility with timing, so and we wanted to get in a few minutes for questions because we have a lot of RSV questions. I think, Cohen, you've answered several of these in some form or fashion, but I think if we just go over some questions again, that would be really good for everybody because not everyone's looking at the questions that come up. So do you want... Just stand here. They're interested to know what the uptake of RS vaccine has been for these populations, and I'm presuming they're thinking about the vulnerable bubs.
Yes, certainly. So this was, we had probably a couple of weeks' notice to prepare for this RSV season, so there was a real rush to try and access families. So one of the great strategies was the neonatal intensive care called all the families that were eligible. They cold called and then recalled them to get them in. I think uptake was excellent, and I think there's lots of communication within our community around RSV vaccine. So there's lots of interest in this at the moment. So we don't have the exact data yet, and I think that'll be really interesting to look at. One of the things we were discussing in the break is ensuring access to vulnerable babies, particularly First Nation babies, and I think that's something we will need to certainly have a close look at in next RSV season.
Because it did have a very short turnaround, and we know that you were the driver of a fabulous response in Hunter, New England, and probably one of the best ones in the state, so well done. Can RSV vaccine be given to, or MAB be given to children that have had the infection, or is that a waste of?
Yeah, well, as I highlighted, it's a very expensive vaccine, so I think it's unlikely to have efficacy, and so the recommendation is only to provide it for those infants who have not had known RSV this season.
And the others are probably ones that you won't quite know, but or don't really know the details yet. But would the plan be to offer RSV vaccine to all pregnant women from 2025, or is that just a hope?
Yeah, I think that's the big question, isn't it? I think some of the reason for presenting the information around the cost of RSV for our communities is to start thinking about that. But I would have thought next year, based on how the Australian Immunisation Handbook is already setting things up, I'm very hopeful that'll be included as part of the NIP.
We all hope so.
Yeah, I don't know the answer to that. I'd love to. If anyone does, please write in the chat.
And we were talking about before, we're hoping that the rush for vaccines is a high this year, and the short supply of it in New South Wales has highlighted people's want for it. People have seen it, the desire for it, so
Yes.
hopefully. Is there any vaccines still around, or MAB still around, available for eligible bubs?
Yes, we do have some dose available. So if there are eligible infants, I've encouraged them to refer them to your local paediatric centre, or you can also refer to our immunisation centre and we can help support that.
Beautiful. And the others are around cost. Will the cost of RSV vaccine ever be reduced, and will it become free and on the schedule?
Well, I think just going back to that slide of the number of RSV vaccines that are in clinical trial at the moment, normally the pressure on vaccine prices is related to the market. And so you could see all those vaccines potentially moving towards clinical implementation. You would imagine the vaccine price is going to come down over time, but that'll also be interesting to watch.
It will, yeah. That's probably all of our questions for RSV. I'd like to really thank you tonight, because it's been an absolute pleasure having you here with just that overview of RSV, because it's been such a hot topic for all immunisation providers, and there's always been a lot of questions around it since it was all done in a rush, and you've just done a fabulous job, and we really thank you for giving up your time tonight. So thank you very much.
Thank you, Sharon. Thanks for having me here tonight. I've learnt plenty, thank you.
You're coming back at some point.
Thank you.
Okay. And just to let you know that any questions that we haven't answered, okay, just here, Kirsty and I are going to stay behind and answer all the questions on Slido. I'll just hand over to Phoebe. I think she wants to close up.
I do. Thank you. Thank you to everyone for joining us. I just want to do a quick whip around the room of a huge shout out to Dr. Cohen Butters. Really impressive presentation, and we very much enjoy having you here. And you enjoyed being here, so maybe you'll come next time. Sharon and the team, Kirsty, Katrina, great presentations. Peter had to run away because he had other commitments, but just overall, one of my favourite events, so thank you so much. To all of our participants online, there was about 400 of you. Thank you for spending your evening with us. We do appreciate that this is your spare time, and the fact that you choose to tune in is very special to us. I have launched the evaluation on Slido. If you could pretty please fill that out, and I will get your certificates based on those evaluations in the next week or so. Thank you so much again. Have a good night.
I can't stop, won't stop. I can't stop, won't stop. Can't stop.
Can't stop, won't stop. Can't stop, won't stop.